Hello and welcome to Differential Discussions. I'm Melissa,
And I'm Dave.
and we're still talking about leukemias. So everyone got sick of us talking about red cells. Eventually, they're gonna get sick of us talking about leukemias.
There's nowhere to hide. It's all hard.
I know. So today we're going to talk about acute promyelocytic leukemia.
And I would argue that this is one of my favorites. I think it's kind of one of the more straightforward. It depends on the presentation, of course, but this particular slide we're looking at, yeah, I can get down with this. I can do this.
Well, the hypergranular variants are easy.
Right.
It's the microgranular variants that are terrible.
Mm-hmm.
So what am I talking about? So hypergranular promyelocytes are generally granular. So when you have when you have really granular promyelocytes, we call that the hypergranular variant. And then when you have granules that you can't see with standard microscopy, then we call that microgranular because you really only see the shading in the cytoplasm. The tough part with microgranular is they look like monocytic leukemias morphologically. It's a challenge outside of that nice butterfly nuclei that we have that's characteristic of APL, but microgranular variants are challenging. Hypergranular variants are nice and easy.
Yeah, typically. As to an experienced morphologist, this is yeah. And I think even with students generally, in my experience, they tend to be okay with APL. So you mentioned butterfly nucleus. What do you mean by that?
It's bilobe looking, but it's got one lobe here and one lobe here. Sometimes a lobe is overlapping another lobe and you can only see partially. That's fairly common, but this kind of bilobing appearance, right? And then it would be like if you had the little caterpillar head and then those little antlers and stuff, right? So that's why they call it a butterfly, because it looks like you've got the two little wings together.
Yep. And so it's not uncommon for neutrophil lineages to want to lobe up, right? But that does not happen in this early of a stage. So that ends up being a really important characteristic where we can look at these and kind of guess the leukemia and kind of know what we're looking at.
Yep. Yeah. The other thing is they're promyelose, so you can have lots of hour rods.
Right.
Usually you see more hour rods in the bone marrow than you do the peripheral blood, but the peripheral blood you can still see a lot of hour rods.
Yeah, and I think what's fascinating about this particular, well, I guess maybe we'll talk a little bit about pathophys because it's kind of relevant in a lot of different domains. But for the students out there that will eventually take their board certification exam, what's cool about this particular leukemia is it has a translocation that we know and is well documented, and that's 1517.
Yep. It's like you're asking me.
I am.
P1517 PML rara.
Yep, PML rara. So we have a fusion, and essentially what the consequence is here is that these cells get stuck in the promyelocytic stage and they can't mature past that. And there's some interesting parts of this where we're talking about the stereochemistry and how retinoic acid is integral in the maturation process. And with this mutated receptor, the normal retinoic acid just can't fit square peg round hole kind of a situation. So you get this freeze in the maturation.
Yep.
Yeah, really cool.
Yeah. And then just for reference, RARA, the PML RARA, the RARA is retinoic acid receptor alpha. That's why we're talking about retinoic acid.
Yes. Yep.
Yeah. So this used to be under old FAB classification. It would be M3, but now that we're under WHO, they don't have it under not otherwise specified. It's actually under the recurrent cytogenetic abnormalities because of T1517.
Yeah, so really easy to kind of identify, diagnose, and relatively easy to treat too. I think we're not really on that side of things, but
well, now that they have ATRA,
right,
that's the retinoic acid in a different conformation, like Dave was just talking about. So we can give them, it's all trans retinoic acid, different conformation, overcomes that ability to bind to the retinoic acid receptor, and so it binds and the cells can proceed past maturation. So it's another way where you can treat for the pathophysiology of a particular genetic abnormality.
Right.
You're not getting rid of the genetic abnormality, but
Right.
you are you're treating it, and you're kind of overcoming that genetic abnormality.
Right. And we would hope that, I guess, the future, the far future, is that we could identify the genetic abnormality of any particular personalized cancer that you're experiencing and develop a treatment that focuses on those particular mutations. At the current rate, most cancers, you cut it out, you burn it out, or some kind of chemical therapy.
Yeah, cytotoxic therapy.
So, and that's kind of, those are brutal. Cool. Okay, so I got us off topic a little bit there, but but morphologically, especially what you'll see on this slide, is they look like promyelocytes. They just have kind of like weird nuclei, right?
Yep,
So,
they're bilobed, and then they have multiple nuclei in them.
yes.
And the cytoplasm is generally a lot darker, like you can see in this guy.
Yep.
At least in this patient's prose.
Right. There will be some variability patient to patient. Also through stages of treatment. Once these patients start to receive therapy, morphology kind of goes out the window.
Therapy, APL treated cells are the worst, the absolute worst. I wouldn't put you guys through that. I don't want to put me through that.
So you see this, like, it wants to be a butterfly sort of, and you actually see the piece connecting the two sides is different in staining than the rest of it. Yeah, it's weird.
Yeah, absolutely. There's the two distinct lobes.
Mm-hmm.
So we've got our butterfly there.
Right. And classification of these cells has always been kind of like bothersome for me, because they're promyelocytes, right, Melissa? I mean, are they the same promyelocytes that are in my other patient that has a left shift? No, they are not. They're much worse than that. So how these things get reported might be variable. Haven't been at a ton of different institutions to know. So just note that we're calling them promyelocytes, but these are certainly very malignant cells that cause a lot of disease.
That's not.
Ooh. Hey, what's up, lymph?
We get lymph.
Ooh. So this would fit into that category of, I saw bad stuff already, so this guy's a bad guy. But it's hard to make out what's going on here, right? It's kind of dark.
Yeah. So this is the nucleus. It's not bilobed. It's just a nuclei, but actually it might be, because it kind of looks like this is also part of the nucleus. But it looks like there's an hour rod here, but it could just be the way the granules are.
Sure.
Yeah, he's weird.
So this is an interesting time too to talk about, these are spheres essentially, right? And if you have two lobes, and it's nice when you see it on that conformation, but say they're more like this, right? So you might subtly see that lobe on the bottom just kind of peeking out on the side. It comes with experience and looking at these things. Yep. So the top one is a bit dark, but I can see two lobes. Would appear to be two lobes to me there.
Yeah, I think so.
Let me get my annotation. So I think
the back one's peeking out a little bit.
Yeah, I thought I see like, yeah, more like this kind of thing. Yeah, and I think I'm seeing what, like this.
Yep,
So yeah, we could talk more, but honestly, once you're seeing that morphology elsewhere and it's clear, then you're just counting at this point. Just think, think, think.
Yep. We're not even too thick, and the cells are like
Very dark.
let me go a little bit thinner.
And that's not a bad thing to kind of talk about a little bit too. Is like, it probably takes a lot of experience to have confidence to say, there we go.
Yeah.
It's a good butterfly.
Much better.
But if you see really strange staining characteristics, like stuff is staining really, really, really dark, I think a lot of people might intuitively think like, oh, it's the stain, like try to blame it on other factors. It might be the cell.
Yeah. And I think in general, these cells are staining a little bit darker, but I think I was just a hair too thick for us to be able to see the details. So this is a little bit better where you can actually see the line.
Yeah, and actually what's interesting too, one of the ways that you can kind of tell that they're separate and distinct is because, what is this, a Venn diagram? Because you get this overlap like this, you end up with this darker area here.
Yep.
And that kind of gives you some kind of a three-dimensionality to what's going on.
Doesn't matter what direction I went in, I moved.
I'll also note to the viewers, I'm not seeing a lot of platelets here, which is pretty indicative. These just two lymphs kissing, like.
Yep.
So really unusual to see lymphs doing this, but it looks like one large granular lymph. Get some granules in there.
Yep.
Hey, a normal neutrophil. Yep. Ooh. So normal cells, right? Like you're gonna come across normal cells. And then this is especially dangerous when we talk about weird butterfly nuclei or whatever, but this is just a monocyte.
Yep.
Literally just a monocyte. So try not to overcall, I guess.
Oh, I went to the edge, but did you see him?
Yeah.
He's kind of, no, we're gonna go away.
A little blurry, but. What? I don't. So like this could be just a totally agranular neutrophil lineage, or
no,
like,
he's a bilobed lymph.
Bilo lymph. Okay, all right.
Yeah, that's a lymph.
I see. This is where I like the nucleus screams lymph, right?
Yeah.
And not uncommon for lymphs to have a pinch or like a kidney bean thing going on. This guy's got a crisis of identity, but
he didn't want to be left out.
Yeah, I guess he's mimicking his toxic brothers and sisters.
Get him?
Very pretty. Very, very pretty.
Oh, wait, I want them both in. Okay, there we go.
Yep. So we have kind of a larger lymph on the bottom, and then a pathological promyelocyte at the top.
Yeah, so this is the lymph, and that's the promyelo.
Yep. So I've seen, Melissa and I have seen quite a few M3s in our clinical work. I don't know incident-wise if they're more common or less common than some of the other. Oh, beautiful.
We hit the jackpot.
These are beautiful, beautiful prolymphs. Yeah.
Promyelos.
Oh,
not prolymphs. There's no prolymphs here.
These are promyelos. Oh man. I can picture my students like to finger wagging at me from me finger wagging at them on terminology.
Yep.
Sorry. Yes, these are promyelos, not prolos. But yeah, these are beautiful. I mean, I don't know what to say. Normally we're trying to describe things, but I think these cells kind of speak for themselves, don't they?
Yeah. Yep. We can try, I guess. These
Yeah.
two bilobed.
Yep.
Really easy to see. The dark blue in the cytoplasm, and then you can see lots of primary granules here and here. And in this one, it's like the primary granules are just everywhere. So it's hard to even make out the nucleus because of those primary granules.
Yep.
Let's look at the other one that's up there. And one more. Wrong direction, Melissa.
Hey, the fact that you keep it organized at all.
Oh, I just pulled them out.
Right there.
Yeah.
Yeah, so this one's a little bit trickier, right? It doesn't have an obvious bilobing kind of going on, but it has a lot of the characteristics still of its brothers and sisters, right? So don't, undercall. Because to me, this is still in the same category as the other promyelocytes.
We just went this. I want to go this way.
Woo. Okay, so now we're at kind of an interesting point where there might be blast forms, right, Melissa?
There could be. Yep.
So I'm looking, or she's looking, to see maybe are there primary granules here?
I don't see any.
So without primary granules, I would think the more prudent classification would be to call it a blast, right?
Yep. Yeah.
So you may see blasts. So
Yes.
it's one of those things where the maturation is arrested at promyelocyte, but you might see an early blast form.
Yeah, absolutely. And depending on the patient, they may have a good number of blasts or a small number of blasts.
Yep.
And you don't usually see much past the pro stage. And when you do, then it has to do with that's not part of the malignant clonal expansion.
That's right.
That's
Very
the
good.
other developing cells that there's not many of them, but when they get allowed to develop, you could see a myelo, a meta, or these other mature cells like we've been seeing because they're not part of the malignant clonal expansion.
Right.
And
I think that is hard to understand as a concept too when you're first learning about malignancies.
Yeah. Well, because you think malignancy, they're all malignant. Well, no, it started from one clone and then he clonally expanded.
Yeah.
So the numbers you're seeing are basically the same cell that just keeps dividing.
Right.
But like this guy took over, but this guy over here is not malignant and he's allowed to mature.
Right.
But when you think about this guy, he's going to mature how he should mature. Right. And this guy is going to clonally expand, reduce apoptosis, get rid of the whole issues where they need to regulate themselves. Whereas this guy still needs to regulate himself.
Right. Yep.
All right, let's find one more field.
Sounds good.
Oh, this is a good one.
Oh, cool. Yay. So visual anchors. So I'm going to look at that cell on the right and I see it's significantly smaller, right? Nucleus is approximately the size of a red cell. Is it the prettiest lymph I've ever seen? No, but it is just a lymph, right? Don't, overcomplicate things.
Yes.
And then is that a lymph on the left, Melissa? What do you No, it's not.
A little bit too big.
A little too big. Little too big, and we got our primary granules, our blue cytoplasm, and then we're seeing that bilobed phenomena.
And he's actually got really prominent nucleoli here, and then another one here. So way too immature to be a lymph.
There's one thing I just wanted to maybe just add. So with an APL, one of the hallmark pathologies associated with it is this hypercoagulability, right? So I know in my experience, I always kind of patted myself on the back and I felt like a superhero because when I saw these and I recognized that there's an M3, I asked the docs to order a fibrinogen D dimer. And I know this isn't a coag discussion. Melissa would love to talk about coag. But in the clinical context, for people that are doing this bench work, just have that in mind, that these people often, if they die early on in the disease, it's because of blood clots. So we want to kind of throw that out there as a PSA, be thinking about that.
No, that's true. And before we had the current therapies, the ATRA with arsenic, patients used to die from bleeding and clotting from the issues related to DIC that these patients go into, because those primary granules contain procoagulants.
Yep.
So you kill off these cells because they don't go through apoptosis, right? You inhibit apoptosis. So they necrotize, they die wherever they are, release their contents, and those procoagulants start coagulation on a scaled level, not at a, being regulated to the site of injury. So that's why hypercoagulability is a big problem with these patients. But because we have the therapy that we do, they don't have it as big of a complication, but it's still an issue.
Right. It's an issue right at presentation, right? So that we need to get them safe in the early stages of disease. But yeah, it's fun looking at this stuff. I love M3.
Me too. All right. Well, I think that's all we have for today. So thanks for watching.
Thank you for your time.
Please like, subscribe, and hit the bell if you'd like notifications whenever we post a new video, and feel free to reach out to us on social media or via email with comments or suggestions about future content. Thanks.